Postoperative complications include pneumonia, acute respiratory failure, and atelectasis. Pneumonia is an infection that inflames the alveoli. The alveoli then fills with pus or fluid. Acute respiratory failure is when a patient has difficulty breathing and is hypoxemic, which is having a PaO2 less than 60 mm of mercury and a SaO2 less than 90%. And/or they are hypercapnic, which is a PaCO2 of more than 50 mm of mercury and a pH less than 7.35. Atelectasis is the collapse of alveoli resulting in partial or total collapse of the lung. Two atelectasis types we will focus on, which are for bedridden and post-op patients breathing without mechanical assistance, are gas absorption atelectasis and compression atelectasis. Gas absorption atelectasis is when a mucus plug causes a halt or shift in the ventilation and perfusion of the lungs. The gas distal to the obstruction is absorbed by blood and a partial collapse occurs. If the obstruction occurs in a larger airway or bronchus, it could cause a full lobular collapse. Compression atelectasis is when the transthoracic pressure exceeds the transpulmonary pressure. This could occur due to small tidal volumes or shallow breaths. It is also commonly caused by mechanisms increasing the gradient. Common mechanism examples are anesthesia, the use of sedatives and bed rest, and painful deep breathing resulting from broken ribs or upper abdomen surgery. Some other possible mechanism examples are weakening of diaphragm or a fluid overload, which is common in hospitalized patients. 8 factors associated with atelectasis are obesity, neuromuscular disorders, heavy sedation, upper abdominal surgery, upper thoracic surgery, poor cough and retained secretions common in cystic fibrosis patients, history of lung disease such as COPD, and bedridden patients. Clinical signs of atelectasis to look for are medical history. Have they had recent abdominal or thoracic surgery? Do they have a history of lung disease? Are they a smoker? Respiratory rate. Do they have tachypnea? Breath sounds. Are there crackles? Do they sound diminished? Heart rate. Are they tachycardic? Chest X-ray. Is there increased density and sign of volume loss or tracheal shift? Lung expansion therapy, also known as hyperinflation therapy, is when you increase lung volume by increasing the transpulmonary pressure gradient. It is a common use for patients at high risk of atelectasis or pneumonia. It is primarily used to prevent or correct atelectasis. And it works off of the same mechanism. Transpulmonary pressure gradient, or PTP, is when high pressure enters the mouth goes to low pressure of the lungs. It is calculated by the alveolar pressure minus pleural pressure. Spontaneous breathing expands the chest cavity, which lowers the pleural pressure, which then increases the transpulmonary pressure gradient. Positive pressure breaths or mechanical breaths push air in the lungs, increasing the alveolar pressure, which increases the transpulmonary gradient. A sigh is defined as an increased tidal volume that occurs 6 to 10 times every hour normally. Sustained maximal inspiration is taking a slow deep breath and holding a preferable hold of 5 to 10 seconds if possible. Choosing the best mode of treatment is done when you evaluate the patient's level of cooperation, their amount of secretions and their spontaneous vital capacity. Then you pick the simplest, safest and most effective therapy. 3 steps of administering a procedure are: preliminary planning. What's the best method? Do they need it? Scan the chart. Implementation. Instructing and applying. Follow-up. Monitoring during procedure and documenting after. Heart rate, respiratory rate, their effort of breathing, set and achieve goals, breath sounds, treatment frequency and education. 8 procedures used to prevent or correct atelectasis are: deep breathing and directed cough, incentive spirometry or IS, continuous positive airway pressure or CPAP, Positive expiratory pressure or PEP. Intermittent positive pressure breathing or IPPB. Early patient mobilization. The METANEB. And the EZ-PAP. Incentive spirometry or IS is a lung expansion technique made to mimic a natural sigh. One version is the volume measuring IS and one version is the flow measuring IS. Implementing IS is done by giving a goal based off of the device's chart. The patient is then instructed to take a slow deep breath and hold 3 to 5 seconds. This should be done with 5 to 10 breaths per hour or a minimum of every 2 hours but only while awake. After all treatments, instruct the patient to cough after. Indications for IS are mainly to treat atelectasis. It can also be preventative if presence of restrictive lung disease or other conditions that may lead to atelectasis are apparent. Contraindications for IS are if the patient can't or won't cooperate or can't take deep breaths. Complications of IS are acute respiratory alkalosis is most common, also known as hyperventilation, as well as pain and fatigue. Intermittent positive pressure breathing or IPPB is a non-invasive ventilation that provides machine-assisted breathing. It has a FiO2 of 40 to 100%. And it increases the tidal volume. When implementing an IPPB, the patient must be conscious and alert. Ideally, a treatment should last 10 to 15 minutes 4 times a day. Indications for an IPPB. They are typically used if an ISP is non-applicable or unsuccessful and the patient has atelectasis. They will improve lung expansion. They can also be used as a short-term ventilator or to deliver aerosol. They are also used in the nursery to imitate a mother breathing for preemies who forget to breathe. Contraindications for an IPPB are patients with tension pneumothorax, which is a laceration in the lung that allows air to build up in the pleural space but not escape. Or the patient has an intracranial pressure greater than 15 mm of mercury. Or they have a recent facial or a lower skull injury. Complications of an IPPB include an increased torque of breathing leading to hypo or hyperventilation, pneumothorax due to too much pressure, and air trapping, autopeep, or over-distended alveoli. Continuous positive airway pressure or CPAP is a positive airway pressure used to keep airways open continuously. This means during expiration and inhalation. When implementing a CPAP, you must be monitoring and assessing the patient every 2 hours. Indications for a CPAP. They are commonly used for sleep apnea or a patient with constant dyspnea. They can also be used as lung expansion therapy to keep airways open. Contraindications for CPAP include unstable patients, untreated pneumothorax, or nausea. Complications of a CPAP include leaks in the mask, and gastric distension, which is bloating caused by air bypassing the lungs and filling the stomach. A METANEB enhances mucus clearance and helps resolve or prevent atelectasis. It was originally made for lung transplant and cystic fibrosis patients. 3 therapies of the METANEB include continuous positive expiratory pressure or CPAP, which is a form of lung expansion therapy used to resolve or prevent atelectasis. Continuous high-frequency oscillation or CHFO, which is used for mucus mobilization. And the aerosol mode. To administer breathing treatments, however, no antibiotics or mucomist should be because they are too thick. This is the common treatment process of the METANEB, resulting in a 10-minute treatment. 3 reasons to end or modify therapy are if the breath sounds are clear and improved aeration, the chest X-ray shows absence of atelectasis or consolidation, or the physical assessment warrants change. 3 positive expiratory pressure devices are the EZ-PAP, the TheraPAP, and the AccuPAP. The EZ-PAP delivers continuous positive airway pressure throughout the breath using a flow from an air or oxygen meter. It operates based on the Kondo effect. It is set at